Good morning, everyone. My name is Tong. I'm an endocrinologist from Malacca General Hospital in Malaysia. Today, I will be talking to you on the risk of DKA during Ramadan fasting. So just to recap for the junior doctors out there, the diagnostic definition of DKA, I always tell my junior doctors, the answer is actually in the name itself. So the D in the DKA stands for diabetes, whereby you must have a blood glucose of more than 11 millimole per liter, or the patient need to be known to have diabetes. And the K, you need to have a blood ketone of more than 3 millimole per liter or more, or a ketone urea of 2+ or more. And finally, the A, or the acidosis, you need to fulfill this, having this criteria of a bicarbonate less than 50 millimole per liter, and or a venous pH of less than 7.3. And if you have any of these features, the patient is deemed to have severe DKA. This include venous bicarb less than 5, or venous pH less than 7.1, a high blood ketone of more than 6, hypokalemia on admission, because we know that with intravenous insulin infusion that we give for treatment, that will cause the potassium to go lower. So if you start off with a low potassium, that would be a danger sign. If the GCS is low, less than 12, oxygen set less than 92%, if the patient is hypotensive, if they are tachycardic or bradycardic, or if the end-ion gap is more than 16. So what are the risk factor of a patient getting DKA? In this registry-based study looking at risk factor for DKA done in Germany, which have a patient of almost 50,000 people, what they found that if you look at the gender, there's no difference between male and female. But if the patient is younger, age less than 30, they're higher risk of getting DKA. If they are migrants, or if they have diabetes between 5 to 10 years of duration, the risk is higher compared to those who have a lesser duration or more duration of diabetes. Of course, logically, if the A1C is higher, the risk of DKA is higher. The types of insulin treatment does not actually increase the risk of DKA. So in this study, they found that higher DKA in those with high A1C, disease 5 to 10 years, migrants, and younger patients. How about during Ramadan fasting? We know that any patient with diabetes have the risk of both high sugar and low sugar, in fact, on a daily basis. However, as we know, Ramadan fasting requires an abstinence from both food and fluid. And if a patient has an insulin deficiency, this would potentiate the risk of DKA, especially if they have an intercurrent illnesses like an infection. Even among those patients with insulin reserve, fasting can theoretically increase the risk of DKA by causing changes in insulin and glucagon levels, as well as fluid levels in their body. In the landmark EPIDIA study, the numbers of patients with severe hyperglycemic episodes with or without DKA were found to be higher during Ramadan fasting. However, in some other studies, they found that the incidence of DKA during Ramadan is actually low. So with this in mind, most of these studies are actually done in a retrospective manner where patients have to recall their episodes of hypo and hyperglycemic events. And with this in mind, and the fact that in Malaysia, the proportion of patients fasting during Ramadan is high, we embarked on this study, which we call Diabetes Emergencies Around Ramadan Study in 2019. So this was a study that was done across the country, and it actually involved 18 public hospitals and covered most of the states in Malaysia. And we done it in 2019, and we looked at diabetes emergencies, patients that were admitted for diabetes emergencies, whether it's DKA, HSS, and hypoglycemia, among Muslim patients who were planning or already fasting during Ramadan or already fasted. So we included all adult Muslim patients with a previous diagnosis of diabetes and who has been admitted for either one of the diabetes emergency. So we look at the month before Ramadan, the month of Ramadan itself, and 1 month after Ramadan. And the definition of the diabetes emergency is as follows. DKA, as I mentioned earlier in my first slide. HSS, they need to fulfill these three criteria, having hypovolemia, marked hyperglycemia with a blood glucose of more than 30 millimole per liter, and serum osmolality of more than 320. And hypoglycemia, as we all know, is when they have a blood glucose level of less than 4 millimole per liter. So what did we find in this study? This is a little bit on the background characteristic of all the subjects. We look at the pre-Ramadan, during Ramadan, and post-Ramadan period. We found that we had a higher incidence of diabetes emergency being admitted in the pre-Ramadan period, followed by during and then post-Ramadan period. There were no differences with regards to the gender, and the mean age of our patient was about 55 years old. And then we compare the hypoglycemia and the hyperglycemic diabetes emergency. So about double the number of the patients admitted had DKA and HSS compared to the hypoglycemia. This is not surprising because a lot of patients with hypoglycemia probably had minor ones and they have self-treated at home. So these are some of the results that we found from DEARS. We had 308 admissions altogether. 13 were excluded from analysis because of various factors. A few of them were less than 18 years old. Majority of the patients admitted had type 2 diabetes, almost 90%. As I mentioned earlier, hyperglycemic emergencies were more common than the hypoglycemic emergencies. And overall, we had more numbers before Ramadan compared to during and post-Ramadan. The most common precipitating factor leading to these admissions was infection, which is again not surprising. And this is followed by medication-related factors, for example, non-adherence or failure to change the dosage during Ramadan. About 70%, almost 70% of our patients did not recall ever receiving any counseling about Ramadan fasting prior to that Ramadan. So this was something that was very important to us. And how about DKA per se? What did we find about DKA from our study? So DKA admissions were more common than the HSS admission. And this is something that is different from the previous studies in other countries. Majority of the patients admitted for DKA had type 2 diabetes compared to type 1 diabetes. So this is probably due to the differences in the pathogenesis of type 2 diabetes in our country, whereby patients tend to have insulin deficiency earlier. Our patients admitted for DKA were also younger than those admitted for hypoglycemia or HSS. And this is the only diabetes emergency that was found to be highest during Ramadan compared to the pre-Ramadan and post-Ramadan period. So I know this is a very busy slide looking at the background characteristic of our patients admitted for DKA. I will go through each section one by one, just to highlight that we had about 119 admissions for DKA, and the highest was during the period of Ramadan. And when we look at, in terms of gender, there was no differences. And the mean age of our patient was 45 years old, and they had diabetes for about 8 years. And as I mentioned, about 3/4 of our patients admitted for DKA had type 2 diabetes, and the rest either had type 1 diabetes and a few had LADA. How about the other characteristic? We also look at whether they received Ramadan advice. And we found that more than half of these patients did not receive any counseling with regards to Ramadan fasting prior to embarking on fasting. The most common precipitating factor of DKA among our patients was infection, and followed by medication-related factors. And so this is something that we feel we can address in the future when we counsel patients for Ramadan fasting. And almost 2/3 of our patients were already on insulin, and this could probably mean that a lot of our patients are already insulin deficient. In terms of macrovascular and microvascular complication, more patients had microvascular complication, but there were no differences among the different periods of time. The severity of DKA also did not differ between the 3 different periods of time. So these are some of the important take-home messages from DIAS. Overall, admissions for diabetes emergencies were higher in pre-Ramadan, followed by Ramadan and then post-Ramadan period. However, DKA admissions were highest during Ramadan. And duration of diabetes among those admitted was almost 10 years, and already almost half of them have some complication, nephropathy. So despite this, 2/3 of our patients did not recall receiving any Ramadan fasting advice in the past. So pre-fasting counseling during Ramadan is very important in all patients, even more so in those with long-standing disease and with complications. So is DKA during Ramadan fasting preventable? I think it is. Number one, we need to recognize the factors that may influence care for patients with diabetes during Ramadan fasting. Number two, we must take the effort to risk stratify prior to Ramadan fasting. And we must remind our patients and our healthcare providers the importance of this counseling for Ramadan fasting. So this is a table taken from the Diabetes and Ramadan Practice Guideline. And I think it summarizes very well the factors that may influence personalized care in patients with diabetes during fasting month. And this can be divided into Ramadan-related factors. So in terms of DKA, a patient, say, had a history of DKA in the past Ramadan, this could mean that the risk is higher. We need to recognize that this is an important factor. In terms of types of diabetes, patients with type 1 are probably higher risk for DKA. Patients with a poorly controlled A1C, or if they have insulin deficiency, and if they are on a newer drugs such as the SGLT2 inhibitor. And in terms of the factors concerning the patient, so if a patient is less motivated, for example, have an infrequent monitoring of the blood glucose, or if the patient is pregnant, so these are factors that we need to recognize. I just want to flash you this table that looks at the risk stratification for Ramadan fasting. And at section 7, it looks at acute complication. So if the patient had either a DKA or HSS, in this chart is labeled as HONC, they have a higher risk of fasting during Ramadan. So if the diabetes emergency is in the last 3 months, they score a higher point. So before I end, these are some of my tips to prevent DKA during Ramadan fasting. So remember the 3 R's. Recognize the factors that the patient have, and number 2, remember to risk stratify. Number 3, I think this is very important. We need to remind and to re-counsel patients about adjustment and adherence of medications, the importance of blood glucose monitoring, and the importance of adequate fluid intake during Ramadan fasting. We also must not forget to remind patients about the sick days rule. I think if we are looking at a type 1 patient, we will always remember to talk to them about sick days rule. But sometimes when we see patients with type 2 diabetes, we may miss this out. So do not forget to talk to patients about sick days rule. And finally, never assume that the patients know. Many a time we have patients with diabetes 8 years, 10 years, and have never received any counseling about Ramadan fasting, or they may have received in the past but may have forgotten. So it is a good time to remind them again. So that was my last slide. Thank you very much for your attention. I welcome any question. Thank you.